Okay, so I think I'm a bit like Adrian, so I might well wander away from the microphone, but I will try not to. And I know there's a thing there which I've got to get used to because I tend to look at the slides and then no one can hear me. I often skip slides as well because I'm terrible with the technology. So apologies if I'm talking on one slide and we're 4 ahead. I've got a lot of slides here today. I'm not going to go into in-depth detail on all of them because I've got a limited time and I've held everybody up, so no doubt Mike will be tapping his watch at me if I'm not careful. But obviously last time I was on this stage was about 2 years ago, and we were talking about the imminent release of the cleaning standards 2020, 2019, 2018, but they actually have been released now, so it's been a really busy year. Obviously launching this, food review and all of the other things, and it's been really great to see the engagement we've had across this programme. Obviously it took about 4 years to actually get these done and out and published, but there's been a lot of talk today about power of partnership. Craig's mentioned it, Phil's mentioned it, Adrian's mentioned it. And it's important that journey for us started with the cleaning standards. We had all of our FM partners as part of the group. We had, FM cleaning companies. We did workshops as well as the NHS as well and the professional associations. So it was a very big working group on this. I think the core membership was roughly 50 people. Not that all 50 got to every single meeting, but we did have a lot of input, which was really, really great. So we're going to go through some of the highlights of the document, what the mandatory requirements are, the cleaning frequency gap analysis, documents, and sort of cleaning manual that's coming out shortly. I know you've probably heard that a lot, but you heard that about the cleaning standards as well, so you'll be used to it. So obviously this project started way back in 2017. It was one of my first priorities when I first joined NHS England and Improvement was to update the cleaning standards that hadn't been looked at for a very, very long time, properly since 2007, the national standards. Obviously we did have PAS in between that, but it was a sort of PAS document rather than a national standard. So we pulled together a large working party from across the NHS. We had input from the Health and Safety Executive, from Infection Prevention and Control. We had nursing, clinical and microbiological leads, the Association of Healthcare Cleaning Professionals, HEFMA as well, the Estates and Facilities Management Association, Public Health Wales and other partner organisations. So a very big project, and we went into it thinking we could do it in 6 months. And it actually took a tiny bit longer than that. So, these replace the 2007 standards. So this is what we want all organisations, all healthcare organisations to conform to moving forward once we hit the compliance timescales for it. At the moment, the only people who are exempt from this are ambulance trusts, mainly because they need a little bit of specialist work. It's also worth noting that with primary care, we're working with a number of CCGs to make the documents a bit more primary care friendly, and to look at areas such as GPs and community settings, scaling down the overall document to be more fitting to them. And some of the add-on documents like the commitment to cleanliness charters are being rewritten to exclude words like chief executive, or take out things like protected meal times, because obviously they're not required for those settings. So you'll see here there's several mandatory requirements. The functional risk categories, they are mandatory. The elements, frequencies and performance parameters, your cleaning responsibilities frameworks, the frequency of audits, display of star ratings, your efficacy checks and commitment to cleanliness charters or display of those. So the 2021 standards aim to reflect modern methods of cleaning, infection prevention and control, and other changes that have happened since 2007. The standards focus on the need for a collaborative approach. We've heard a lot about the power of partnership, and it's as important in cleaning as it is in food. There are responsibilities. Cleaning is everybody's responsibility. It is not just about the cleaner or domestic on the ward. It is everybody from the chief exec right down to the domestic member of staff, and everyone needs to take a hand in how this happens. So there's a suite of documents that's available right now. You've got the actual standards themselves. There are appendices that have all the attached documents in that help you conform to the standards. We've got the health and safety document, which is additional guidance that sits alongside it, as is the pest control, to give advice and guidance on how things should be done in those areas. And then shortly to be coming the National Standards of Healthcare Cleanliness 2021 Healthcare Cleaning Manual, which replaces the old revised NHS Healthcare Cleanliness Manual. So looking at our functional risk categories, obviously we had 4. For a very long time we've had 4, and this has actually been upped now to 6 categories, and they're called functional or FR 1 to 6 categories, rather than our old very high risk, significant and low risk. The 2 ratings have been added to help flexibility across different types of organisations. For a long time we have heard people say that the standards are very acute focused and there's no room to move things around. So the addition of the 2 categories help organisations to be able to place rooms, areas and buildings into the right categories. They can basically, there's also a blended risk category that has been put into the standards, which is optional for people to use, but it's a way of expanding how you do things. It means that you don't need to have one area all as very high risk. You might just decide to have part of that area as FR1, and it will be down to individual organisations to decide whether that is right for them. You don't have to do that. I will stress that. Slightly more complicated. You will need an auditing system that's electronic. It will be almost impossible to do that blended approach using a paper-based system. But we'd like to think in this day and age that everyone, if they don't have it yet, is well on their way to getting one of those systems. I think I've broken it already. Oh, has it gone? Okay, brilliant. So I told you I'm really bad with these. So you can see here that the FR1 replaces what was very high risk. FR2 replaces high risk. We've got FR3, which is a new category at 90%. The FR4 replaces significant risk. 80%. FR5 is a new risk category, and then FR6, 75, replaces the low risk. And obviously I've just mentioned the blended approach. So, you know, the governance of them, you don't have to adopt all 6, and it might not be suitable for all organisations. For example, if you are in a GP surgery, you may not have any FR1 areas, so we're not going to insist that you adopt all 6. However, certainly in acute settings, it's considered good practice to adopt all 6 functional risk categories. You need to think about, you know, why have you put places? Yes, in the document there is guidance for where you place things, just like you've had since 2007. We've tried to expand on that, but it's not an exhaustive list, and we haven't listed every single room across the NHS because it would be impossible and mean that you would be up for 6 weeks straight trying to read the document. So what we've done is sort of saying, actually, as an organisation, you take our guidance initially and then look at other rooms and see where you would place things, and then you need to document your rationale for that. You need to review that regularly because, as we know, things change. In healthcare, how often does it happen? You know, the domestic goes in today and it's a cleaning cupboard, and tomorrow they turn up and it's been turned into a clinical room, and nobody's told them. But they're still cleaning it at that same old frequency. So it's important to regularly review that and keep a written record of what all your functional risk areas are listed at. So, you know, looking at the elements, the performance, parameters and cleaning frequencies, there is now a list of 50. We've known it as 49 elements for a long time, and I expect most people will still call it 49 elements because that's kind of what's ingrained in our head, and it will take a while. Again, not an exhaustive list. This went round the houses quite a bit, actually. I think we started with 49. At one point, we went up to nearly 70. I think it went down below 49, and we rested on 50 in the end. But like you've always been able to do, you can add to that list. And obviously, if an element doesn't exist in your organisation, you do not have to score it, and you don't have to include it in your list. The performance parameters, same as we've seen before, so that is the expected standard of cleaning for each element. And then you've got your cleaning frequencies, which have always been broken down by the functional risk category, so that's no different. We've still got very similar things that we're very used to doing. So you'll all be familiar with this type of chart. It was contained in 2007. The only difference here is instead of having 4 categories across the top, you've got 6. But equally, some of the elements, obviously that aligns to the new elements and where they are and how they've changed. And we have tried to look at it slightly differently as well to make sure that the parameters for cleaning there are right for it. I think we had quite some long conversations as to why we needed to suggest that bodily fluids and blood should not be present in a microwave. So we've tried to have a look at it and review that. But the standard is pretty much what it's always been around, ensuring that they're clean with no blood, body fluids, dust, dirt or debris. So cleaning responsibilities, again, this has been around a long time. This is about ensuring that not only the staff in your organisation, but everyone around them and the patients understand whose responsibility it is. Now, this doesn't mean, this is an opportunity for you to say, actually, we could do this slightly differently. And that's what we want organisations to do, is think differently about how they do things. We know throughout time, estates and facilities, you know, when something goes above hand height, it becomes hard FM. Not sure why, but it's always been there. And it's similar to these sorts of things. We've got nursing responsibilities, we've got domestic responsibilities, we've got estates responsibilities, but we can look at that differently. If it works well, what you're doing at the moment in your organisation, that's brilliant. But actually look at things slightly differently. Let's put the experts in charge of cleaning things. We don't go around trying to put cannulas into patients, so perhaps we shouldn't ask nurses to go around doing the expert part of the cleaning. There's always going to be a part of their job between patients. It's not about abstaining people from responsibility, but it's about putting the experts in charge of what people should be doing. So again, you will be familiar with a similar chart like this. What we've done this time, people ask for suggestions. Where do we think cleaning responsibility lies? Now, we've given you examples. You do not have to use them, but what you do have to do is fill in what you do in your organisation. So again, it's coming back to thinking differently. This all started from a place where, you know, we were hearing all the stories, and we all do it in lots of organisations. So we get a discharge and we need the bed space cleaning. So we have a nurse or a healthcare worker come along and strip the bed. They wash down the mattress and they put that back on a dirty bed frame. They then call the domestic team, who take that now dirty mattress off the bed frame and put it on the side, clean the bed space, clean the frame, do all of that, put the dirty mattress back on the clean bed frame and call a nurse to come and make the bed. Well, that's a lot of steps, and does it actually make sense? Because the biggest part of that people have said, well, we can't ask domestics to do, is check the mattress for ingression. So how about a domestic comes along, they strip the bed off, they clean it all down properly, the mattress, the bed frame, the bed space, everything, and then the nurse comes along, checks that the mattress is still fit for purpose and makes the bed up. We've sort of gone from a lot of steps there to 2 steps. So it's about thinking differently. It's about changing the way we do things. So again, audit frequency, very similar to what we've seen before, but with the new additional frequencies, we've got an additional every 2 months audit and an every 3 months audit that has been added in order to help people space things out and do things at the right frequency for their organisation, dependent on the risk of the area they're looking at. Star ratings. This has been a really fun one. It's known as the Marmite of the new cleaning standards because people either love them or hate them. And the idea behind this is actually to show what we do well all the time. A lot of people said, oh, but my trust will get really annoyed if we put up a 2-star rating. But what we're seeing from what you guys tell us every single day is that cleaning scores are pretty consistent. It takes a major event like they've suddenly changed the use of this room to take you from a sort of high score, pass mark in the green, to a very low one. So the chances are, if you have got 4-star or 5-star cleaning in your ward, it will remain that unless a major incident takes place. And obviously in some instances it wouldn't be appropriate to audit. You know, if the ceiling's falling down and the place is flooded, it's not the best time to go in and do a cleaning audit. So, you know, generally these are about transparency. We have asked for them to be implemented slowly. So initially it's about making sure all organisations are displaying their cleaning scores, and that wasn't happening. It might be now, should be happening now, but people weren't. The other idea behind the star ratings is that people, essentially for patients, this is easier to understand than a 98% or a 75% or any of those types of areas. So this is an example of what the star rating posters look like. And as I said, the initial thing was around displaying your cleaning scores, then moving on to your star ratings for domestics only, but within 18 months, it has to be a combined score because cleaning is everybody's business. It's everybody's business. We had a lot of trusts that said, well, we don't really talk to our estates department, or we don't have a great relationship with the clinical teams. So this is the opportunity to make those relationships and ensure that you can say to the estates guys, look, you haven't cleaned my radiators, and it's bringing down the score of the ward, and it's meaning a 4-star instead of a 5-star. Or is there another way our team can support you to do those cleaning elements? So, efficacy audit. This is new. I mean, obviously around the audit, so we always had our technical audit, followed up by a managerial audit, which is a manager going around to do just what your supervisor just did, and then obviously external audit. So we've still got 3 levels of audit, but we've removed the managerial audit because we employ our supervisors and our cleaners for a reason. And therefore we have to trust that we've trained them properly to do a visual inspection, which is what we're asking them to do when they do a technical audit. They're not going out necessarily. In some organisations they might be going out with little sort of UV lights and kits and things like that, but mostly we're not swabbing areas, it is a visual check. The efficacy is designed to give you a bit more confidence in the processes being used. So it's designed to look at, are we training our staff properly? Are we using the right equipment? Do we have the right equipment? You know, is a very well-meaning cleaner doesn't like the chemicals that you're buying, nipping down to Tesco's and buying something that they think looks better or smells better. It's about ensuring we're doing things right, and that gives you some paperwork behind what is done so that we can see, so that we can see that we have got the right processes. Coming back to what Adrian said earlier around linking, you know, estates things and all of that sort of thing, thank you, into what we do, it's that type of thing. It's giving us some compliance checks behind what we do. And this is just the first step. You know, we'd like to be in a process where we've got things like APs and CPs and everything like that for domestics as well. So this is an example of what it looks like. At the moment, obviously it's scored. There are questions that are optional at the moment because, again, coming back to where people were saying, well, we don't have a good relationship with our estates team, so we don't know what goes on with the water safety or things like that. So it's optional at the moment. But again, coming back to that, everyone should be involved in this. We are not suggesting that every time you do an audit that an entire team of nurses, doctors, estates workers and, you know, domestic staff are ploughing through the wards. It's not feasible. What we are saying is that people take an interest, that the director of nursing has an interest in all of this, working with infection prevention. You know, how can you join other audits up that go on around the wards? So, commitment to cleanliness charter, again, since 2007 we've had this need to display work schedules. But again, coming back to the fact that in this day and age, we've got a dynamic workforce. So what happens? The domestic turns up on the ward at 7 o'clock. The work schedule says they've got to go and clean these toilets, but the nurse in charge says we've had 4 discharges overnight. Can you get that done first? Because we've got people waiting in A&E. So straight away, they've failed because they're not where we said they'd be. And do we really need to know that? Do we really need to know, and does a patient really need to know that at 7 o'clock someone's cleaning the toilet? Or do they want to know, actually, this toilet gets cleaned once a day, twice a day, 3 times a day? So the Commitment to Cleanliness Charter is about showing everybody that there is a commitment from the top down in the organisation to cleanliness and a clean and safe environment. It is then about showing whose responsibility it is to do things and saying the frequency of that clean. So if you are in a bay and there's a toilet right next door to it or within the bay, you can expect to see that cleaned X number of times per day. So straight away, the staff and the patients know exactly what they're expecting to see. Not necessarily what time, and it doesn't have to be an exact thing, but we know it's being spaced out and cleaned regularly. So this is an example of what it looks like. Again, we talked earlier about, protected meal times and things like that, taking stuff like that out for primary care because it's not appropriate. But we do talk about, obviously, the colour coding and obviously whose responsibility it is to clean things, how often they're going to be done. And there's something there about what we're doing, but also what we're asking the public, patients and visitors to do. With the best will in the world, we're never going to have enough money in the NHS to put a valet outside every single toilet in the NHS. And it's only as clean as the last person that used it. And we're a healthcare establishment. We know people have accidents, and that's fine. But actually, it's quite simple. Please tell us. Just say, oh, I'm really sorry, so we can get someone straight there. So hopefully no one else has to walk in on that and it doesn't sit there for a long time. So then, we've talked about things like frequency gap analysis. This is important for organisations to sit down and look at what are they doing now. We do know, when we started this project, I naively assumed that everyone was fully compliant with 2007 standards, and that wasn't the case for many reasons. Budget cuts, they've found a slight hybrid, they're on a PFI that was signed in 2001. There are loads and loads of reasons. So it's really important to start looking at, well, where are we now and what do we need to do to meet the new standards? So this is an example of a gap analysis. We do have this available. If anyone does want this document, they can get it off us by emailing either our Estates and Facilities mailbox or myself. And that will show whether you've got something that's new, whether it's a change in frequency, whether it's going up, whether it's going down, whether it's staying the same. And this, Mike will be glad to hear, is my final slide, is an example of what the healthcare cleaning manual is going to look like. I'm not going to stand and give you a date purely because it's ready now, but it does have to go through a publications process, and that sometimes slows things down. I am hoping within the next 3 months it will be out, if not sooner. The minute it's ready, it will be uploaded. But it covers not only your written methodologies, it gives some additional advice, but it will cover your written methodologies, so they're the detailed ones, really goes into a lot of detail. We've got the posters, you can see examples of those here. So you can print those off and use them as, or put them in your own training manuals for staff. You can use them for refreshers, you can display them in areas. And then each of these posters will link to a bite-sized training video that is free, basically, at point of use. So as you're training your staff, you can run them through each of these posters and the training videos and sign them off for them. So it should be a helpful training tool for everybody as well.